Arun Singh sir and my dear friend Ashish for inviting me here. My association and friendship with Ashish goes back to 10 years, and we were trained by the same guru in Glasgow at the Golden Jubilee Hospital. We both trained for navigation with Fred Pickard, who invented navigation in total knee arthroplasty, and Dr. Kamaldeep. So, thanks for inviting me. I'll ask the chairpersons to give me additional 2-3 minutes. It's a long topic to cover. I can write a whole book on this. So I am trying to club two my talks. One was for painful total knee arthroplasty, algorithmic approach with the same one. The pointer is not working. Anyways, this one, okay, thank you. So why would the knees fail, actually? If you don't follow the basic principles of soft tissue balancing in the medial lateral plane as well as in the flexion extension, and the bone cuts are not taken properly, the joints would fail. And they would present as aseptic loosening, instability, malalignment, component malpositioning, or maybe periprosthetic fractures and infection. So history in clinical examination is of utmost importance when you see. So you might need to know that whether the patient has night pain, which might indicate infection or a joint effusion. If he has pain on descending stairs or rising from the chair, there might be femoral malrotation or a flexion gap instability. Anterior knee pain points out to the patellar tendinitis and the patellar maltracking. The posterior knee pain points to the posterior capsular tightness or popliteus tendon impingement. So the history is very important. If he has pain on full extension, there might be a soft tissue impingement or a posterior capsular tightness. And startup pain and recurrent effusions indicate towards instability and component loosening. So preoperative workup is usually essentially to know the blood markers, CBC, ESR, CRP, and they should be within the normal range. You always, whatever may be the cause of a revision or pain, you have to actually rule out infection in all the cases. So you must aspirate, the patient should be off antibiotics for at least 2 weeks, and at least 2 cultures within 2 weeks should be positive for a definitive diagnosis. Radiographs do help you to know the initial changes and advanced bone loss also. Orthoscanograms would help you to know about the malalignment, malpositioning, and stress fuse would tell you about the ligamentous laxities. CT scans, as I'll show in my cases, would be able to tell you the bone defects. And Mars MRI would help you in delineating the aseptic loosening. So what are the goals of revision surgery? Obviously to preserve the viable host bone, reconstruct the defects, restore the joint line, get a neutral alignment, stabilize the ligaments, and get optimal patellar tracking and optimal functional joint. The exposure usually in my cases of revisions, 90% of the times a quadriceps snip would suffice, and it's a very simple procedure. If you have a tight knee, you can just go ahead, and this is the quadriceps snip being done, you can see here, and just at a 45-degree angle, I'm just cutting the quadriceps tendon obliquely 3 to 4 centimeters above the upper pole of patella. For joints which are fused in extension or would have a patella baja, you would actually prefer using a tibial tubercle osteotomy, or another exposure which is a VY quadriceps plasty, which is being reported or recommended. I have never used it. In 90% of my cases, I would be able to go away and get away with the quadriceps snip. Prosthetic extraction of the femur is usually done with a thin saw blade and giggly saw wire. You can use flexible osteotomes as well, and then use the extraction instruments, and it can easily come out. Make sure that you do not cause further iatrogenic bone loss. Similarly, on the tibial side, you can use a thin saw blade, giggly saw wires, and this technique called the stacked osteotome technique, where you can put an osteotome one above the other and gently tap out the tibial tray. The rationale for prosthesis selection is of utmost importance. Once you've removed the implant, you must assess the bone loss according to AORI classification, and then you will see whether it's type 1, type 2A, B with damaged metaphases, or a deficient metaphases, as you may see in advanced cases, where you might have to use a RHK kind or a tumor prosthesis kind of implant. Bone loss, why would it happen? It would happen due to stress shielding, osteolysis, osteonecrosis, infection, mechanical loss, and during removal of the components, which needs to be taken care of with either space fillers like cones or sleeves. And you must get a zone 2 fixation with these implants so that you have a stable joint. Joint line restoration is of utmost importance because if you don't restore the joint line, you will have mid-flexion instability and the patient will have, maltracking of the patella. So it is usually recommended that the joint line should be 3 centimeters from the medial epicondyle, 2.5 centimeters from the lateral epicondyle, and almost 2.2 to 2.5 centimeters from the tibial tuberosity. Another thing which can help you out in joint line restoration is actually your residual medial meniscus in the revision cases. Gap balancing, there is a whole flow chart for that, but the basic thing you need to understand is that tibial cut affects both flexion and extension, and the distal femoral cut affects the extension. So once you're trying to balance that, see what is the problem, where is the problem, whether the flexion, like in this case, you see the flexion is tight, and if the extension is also tight, you can use a thinner insert or resect additional proximal tibia. But if you see that the extension space is loose and the flexion space is tight, you can shift the femoral component anteriorly, you can downsize the femoral component, you can resect additional proximal tibia. So there are different ways to go around it. It will take almost 20 minutes if I start explaining this flow chart, but that needs to be followed up. Aseptic loosening in this case. So I'll take some cases now. Aseptic loosening, almost 19 years after the surgery, you can see the defects on the proximal tibia. The femoral defects could be delineated using the CT scans. And these were the intraoperative defects. Mind you, they are always more than what you see on the X-ray. So this is the femoral defect, huge defect on the femoral side, huge defect on the tibial side, all reconstructed using sleeves. Intraoperative picture, and this is almost a 5-year follow-up of the same patient. You can see the sleeves have been used on both the femoral and tibial side. Another case, 74-year female, index surgery done 8 years ago, pain and difficulty while walking. She was obese, and ultimately she got a varus collapse of the tibia. The infection was ruled out by aspiration, and ESR CRP were normal. This is the gap which you see intraoperatively, and the tibia has subsided. This was the defect after removal. You can see a huge medial bone loss there on the medial side, and that needs to be reconstructed. So I've prepared for the sleeve. Then this is the final preparation, and the sleeve has been placed. You can see the sleeve is still medially uncovered because there's a lot of bone loss, but it got perfectly good engagement. The femur had to be revised accordingly, and the same technique followed. Final reconstruction done on table with the sleeves on the tibial side, and this is the final outcome of the patient. You can see the flexion extension and almost a year of follow-up. She's doing fine. You can see here that there was a huge massive defect here. I put in cement here because this part of the sleeve is actually not porous coated, and then when you are reconstructing that part, it needs to be stabilized. PJI is another thing which needs to be addressed. This patient had dire debridement, enterococcus grown, severe loosening on the femoral side, you can see here, and infection proven. Stage 1 was done, femoral component removal, then articulating spacer was placed inside. Stage 2 done after 3 months. And you can see that the joint was reconstructed gradually as according to the defects. And these are the final outcomes. You can see the patient is mobilizing well now. Instability can be another reason. This patient had index surgery done 5 years ago, had a trivial fall, and you can see the lateral opening up, gross lateral opening up and malalignment now. He had been walking on this. So this was the primary X-ray. This was what was done. This is the immediate post-op somewhere done. And then this is how he was a year ago. And this is how he comes to me now, and you can see the gross laxity there. See, so a lot of instability that needs to be addressed. The only way you can do it is with revision, and I had to use a constrained implant in this. I've used the sleeve on the femoral side, you can see after preparation, and this is S from Noyles, which I have put in, and these are the final outcomes of the patient, and he's mobilizing well. Global instability can also be a reason for sometimes failure, and that may be because of the abnormal mobility or due to some kind of activity by the patient. You can see the femoral component is loose, and it was grossly loose both in flexion and extension. You see this patient, this is flexion grossly loose, and in extension also it is medial-laterally pretty loose. So I had to revise this. And this patient was revised. This is the intraoperative picture, the femoral component removed, tibial component removed with the stacked osteotomy technique. And the defect on this side, you see this on the medial side posteriorly, it was built up with the wedges, and this is the final outcome, and the joint is stable on table. So this is how you can address the instability. You need to get the balance right in flexion and extension. Another case of component malpositioning. So here you see this patient had anterior knee pain and this flexion was restricted to less than 80 degrees, and this you see here the patella is maltracking. And I got the CT scan done, and you can see the right side and the left side, this tibial component is internally rotated too much. So this needed revision. Obviously, I could not get the patellar tracking back without revision. This is the tuberosity, and this is the medial placement of the component in the tibia. Done in the original surgery, I had just revised the tibia with a longer stem and a constrained implant. This is the final outcome of the patient. So sometimes such kind of patients do better once you change the component rotation and do a double breasting of the vastus medialis obliquus. So that is very important that you do that simultaneously. Arthropfibrosis. This patient had multiple MUAs, surgeries 2 years after, and even an arthroscopic adhesiolysis. There was no infection. This is all the movement she had. You see multiple scars and arthroscopic scars. And you see the component, the femoral component is malpositioned. That might be the reason for her, not getting good movement post-surgery. And I had to revise it on table, extraction, femoral side extraction. I tried to build up the defect. I tried more of cutting tibia more than getting the extension gap. Still I couldn't get. You can see hardly there is any gap even after I've removed the tibial plate. And ultimately I had to revise the femur because I had to, do distal femoral dissection to get my extension gap. And this is the final revision. And you can see I'm able to get the full flexion and full extension in the patient once I have revised the cuts. And I had to redo this. I put her on extension block splint just so that she doesn't develop flexion contracture again. Periprosthetic fractures can be annoying sometimes. Trivial fall at home, Rorabeck type 3, supracondylar fracture, severely comminuted and just at the level of the joint line. This is something which is very difficult to fix. And the bone is not adequate enough for you to put in a plate, and even if you put in a nail, sometimes the alignment is not proper. And you can see actually this patient had a lot of gross laxity during surgery, and it was revised to LPS and a constraint prosthesis, and I used a sleeve, and this is the final outcome intraoperatively and the post-op. So every patient who needs a revision is a different case. You need to have all your armamentarium ready, and you need to have all constraints of implants, right? From a PS, I've done revisions with straightforward PS and stems also, with varus vulgar constraint like TC3 and LCCK. And you must have, if there's a lot of bone defect on the metaphyseal region, you must have probably a tumor process kind of thing or a S. rhamnoides kind of a hinge available on table. You must achieve a flexion extension gap, which is the primary aim, and you must build up the defect in the bone with a sleeve or a cone or whatever kind of implant you're using. You actually have to build up the joint line with a stable prosthesis. I thank you for a patient listening. And this is my book on knee arthroplasty. You can actually read a lot about revisions in this part. There is a separate section on this. Thank you.
Yeah, thank you, Dr. Mrinal. Wonderful talk and wonderful case presentations. So I know it's very, very tough. So questions from the audience, I have a couple of them, if you don't mind. So how do you work up your patients? Like how you rule out infection, that's the most important question. So what's your general workup, 1, 2, 3, 4?
So number one would be obviously X-rays and CT scans, and the blood component, I've told you ESR, CRP, even if they are little elevated, I would still aspirate. Every revision, I would aspirate. Because there can be a low-grade infection there which might not grow. I have even had tubercular infections which were not growing anything in revision. So you should always aspirate. The patient should be off antibiotics for any revision case. Okay. So that you don't have, infections, like a surprise. Intraoperatively also, I do send samples from 4 or 5 places. If it's not a proven infection, still you should send samples intraoperatively.
Yeah, of course. And if it's nothing came out on aspiration, culture is not positive, you go for a one-stage surgery?
If culture is not positive?
Yeah, culture is not positive.
See, if you have a dry tap, I would suggest that you should.
No, it's not a dry tap.
Okay.
So there was something came out, you sent for the culture.
Then I'll go for single stage.
Extended culture didn't grow
I'll
anything.
go for single stage, definitely.
Okay. Any point that you will change your pral interop? At any time,
if
even the culture is negative.
I do send it for frozen section always, and if it shows more than 10, 5, more than 5 is actually the numbers. If it shows more than 10 neutrophils per high power field, then I would avoid doing a single stage.
Right. Okay.
Thank you.
Thank you. Any other question or input from the audience on 2 stage or 1 stage or in general revision surgery? No? Okay, so wonderful talk.
Thank you.
Thank you very much. Okay, so I think we'll call this session to an end.